It is my huge pleasure to introduce our speaker today, Frank Rauch. Frank and I, Frank is much more important, but Frank and I both work on the Osteogenesis Imperfecta longitudinal study. As you heard, he's going to co-chair the meeting at ASBMR, and he is just another extraordinary multitasker. And so it's grand that he's going to talk to us today about the histomorphometry of rare bone disease. Welcome, everyone, and thanks, Frank, for being here.
Okay, thank you, Laura, for the introduction, and Michael. So I'm going to talk about histomorphometry and sharing my screen here. Okay, sorry, I have to open it first. Okay. Sorry, I don't see it. I have to do it again. Sorry for that. Here we are. All right, so now you should have it on your screen. So, histomorphometry of rare bone diseases. It's quite a esoteric topic for this series, but I will try to make it approachable. So histomorphometry. So first of all, my disclosures here. So histomorphometry, what is it? It's a complicated word to start with. It's a quantitative assessment of bone histology specimens. So it's different from pathology evaluation of regular sections of bone tissue, of any other tissue, in that it's not just descriptive, it turns the pictures into numbers. And why would you need these numbers, or what do you want to do with it? Well, there's two applications for that. You can compare the numbers that you get from these measurements to reference values, like for any other clinical test. So that would be the clinical application. And then, of course, you can also put in the results from several samples, several people into one group and do statistics on that. So that would be the research application. And you can see here two pictures. On the right side, you have an entire bone sample. So we're going to go through that in a bit more detail. And on the left side, you have a higher magnification where you see individual trabecula. So first of all, I would like to talk a bit about how bone histomorphometry was developed. And two important people in the development of histomorphometry were Harold Frost and Michael Parfit. Frost was an orthopedic surgeon and Parfit endocrinologist. And Harold Frost developed some of the methodology that we are still using in this. And I think that's quite important to understand why, what the contribution was and why it was necessary. So the first step for doing histomorphometry is to be able to prepare bone sections that are not decalcified. So typically, when you send a piece of bone to pathology, from the OR, for example, this piece of bone will be decalcified, and then you convert it into soft tissue. And with that, you can cut it like any other piece of tissue sample. So then you end up with something that you see here on the right side. So you can still distinguish bone and bone marrow, but you don't distinguish the mineralized bone from unmineralized bone. And to do that, to distinguish mineralized and unmineralized bone, you need to have the bone tissue with the mineral inside. And then you get images, which is here on the right lower side, where you have clearly unmineralized bone in red, mineralized bone in green, and you can also see the bone cells, the osteoblast and osteoclasts in the same section. And this technique was like the first step that Harold Frost developed in about 60 years ago to develop histomorphometry. The next step is to be able to see what bone cells are doing, how active they are. And that's quite interesting, actually. So Harold Frost, he noticed that tetracycline is attaching to bone and can be visualized under fluorescent light under the microscope. And he was looking at bone sections from an amputated leg in a person who had received 2 cycles of tetracycline for clinical purposes, and he noticed that there were these bright lines that became apparent, and this corresponded to places where bone formation happened. And so then he had the idea that this could be used systematically to label places before you take a bone biopsy to measure the activity of bone formation. And this is what is done here. What is done here on the right side. So this is a trabecular taken from a patient who received 2 cycles of tetracycline before the biopsy was taken. So the way it works, the tetracycline is floating in the circulation, is attaching to bone surfaces, individual trabecula, for example. When the concentration in the serum goes down, it will diffuse off the bone again, but is trapped in places where bone formation happens. So that's why we see these bright lines, because that's a trapped tetracycline, and from that we can measure the activity of bone formation. So Frost developed the methodology to a large extent, and then many labs did this method, but they had their own ways of doing the measurements and calling the different measures. And Michael Parfit brought a bit order into this field, and there is this paper from 1987 that defined the terminology of histomorphometry. And then there is 25 years later a newer paper that is describing the histomorphometry terminology as it's used at present. So that is like how histomorphometry developed as we know it now. So, well, we have some practical issues also to consider. I mean, not many people deal with histomorphometry on a daily basis. So I just would like to show a bit how the biopsies are taken, what to consider there. So the typical place where you take a piece of bone for the purpose of bone histomorphometry is the ilium. So here is the schematic of the anterior superior iliac spine and the entire pelvis and femur here. And the place where the biopsy should be taken is behind the anterior superior iliac spine. And then as shown on the right side, you can see that you take a biopsy by going through the ilium with your biopsy needle. And that biopsy needle should be about 5 millimeter in diameter. So you have enough bone inside, because what's inside of the biopsy needle is then your biopsy sample. And one thing that just in terms of terminology should be mentioned is that you try to do a trans-iliac biopsy, you try to avoid the iliac crest, which is the top of the ilium here. So it's not really correct to call it iliac crest biopsy. Iliac crest is, for example, done for the diagnosis of leukemia when you take an approach from the top and you go between the 2 cortices into the bone marrow. In bone biopsies, we try to get both cortices. We try to get across the entire wall of the ilium. So here is the equipment that's a bit more clearly shown. The most important thing is the needle, because that's where the biopsy will be inside, and typically the needles that are used are 5 to 7 millimeters in diameter. If you do the biopsy with a needle that's smaller, well, then you don't have enough tissue to make good measurements. Like in anything that we measure in science, you know, you need a certain amount of observations in this space, trabecula or osteoblasts, to have not too much variability in your results. So you need a certain amount of tissue to have good histomorphometric analysis. All right, so in the end, we ended up with this sample. The diameter of the sample then reflects the diameter of the needle. So in our case here, 5 millimeters, and the length of the biopsy sample in the other direction represents the thickness of the ileum. In histomorphometric terms, that's called core width. So that's basically the size of the sample, and that's just in a normal situation around 10 millimeters. And you have a cortex and another cortex on the outside, and you have the trabecular bone and the bone marrow in the middle. So if you want to have more details on how to take the biopsy, there happened to be a recent ASBMR webinar on that, where it was discussed how to take the biopsy, and there is a nice video on the ASBMR website under the webinar series tab, and you can see a 10-minute video on how to take a bone biopsy. So we will not go into more details in that. So I'm sitting in the lab waiting for biopsies to arrive in my lab, and this is what I expect to see. So they arrive here after they were taken. They are put into vials, and then they are shipped in this liquid. And a good sample should look like shown here on the right side. A cortex on one side, and this whitish area is the other cortex, and then the trabecular bone in between. So again, a similar nice sample shown on top here, and then once you cut it and stain it, that's what you get. An intact sample with 2 cortices and trabecular bone in the middle. If the sampling procedure is not so successful, then you end up with a crushed sample. And in the end, we see something that I call bone dust, just a lot of fragments that is not really very useful for analysis. So that unfortunately can happen, especially if people have not done many biopsies before. So it's not that simple sometimes to take a good sample, especially if the bone is quite fragile. All right, so we receive our sample in the lab, then we embed it into plastic. So that's a big difference to regular pathology. We don't put it into paraffin because the bone is hard, so the embedding material must also be hard, and we put it into plastic. Then it's cut with a special microtome. Then we need to stain it like any other pathology sample, and then the histomorphometric analysis at the end. We do 3 different types of staining for samples. That's like the standard procedure. One staining called golden trichrome. In that, mineralized bone is green or bluish. Then the osteoid unmineralized bone is red or orange, and you can see also the cells, osteoblast and osteoclast here. We have another staining procedure with toluidine blue, and these sections, when you look at them under polarized light, they show the bone lamellation, which indicates how the osteoblasts were placed when they formed the bone that you are seeing. So that can be quite interesting, and it can be of diagnostic value for different kind of conditions. It's also a nice staining to see the bone cells and the bone marrow cells. And finally, we have an unstained section that we use to look at under fluorescent light, and that's used to look at the tetracycline level. So how does the tetracycline get into the patient? Well, they have to take pills for that, and we have here the schedule. So a biopsy is to prepare basically over a 3-week period. You take the tetracycline pills on day 1 and day 2, and then again on day 13 and 14. And so then you can measure, once you have taken the sample, the bone that was formed in these 2 weeks. And you take the biopsy, on day 18, 19, or 20 after the start of this whole procedure. So that's like the standard approach. So what do we want to measure once we got the sample? So this is in the entire sample in schematic form. So there is different types of parameters that we try to get from a sample. The structural parameters, that's like the size of this sample, which I already mentioned, is the core width. Then you can measure the cortical width or cortical thickness. And then one of the most important measures from the structural parameters, it's how much trabecular bone there is. That's the bone volume relative to the entire volume of the bone marrow space, which is called tissue volume. So this relationship, bone volume per tissue volume, that it is similar to what we measure as bone density in trabecular bone. So and that's abbreviated as BVTV. You hear often people talk about BVTV also with in presentations on high resolution PQCT. So that corresponds pretty much to the same thing in bone histomorphometry. A bit confusing is the fact that tissue volume is really a strange name, I find, for the entire region of interest of your trabecular bone. So tissue volume is simply bone marrow plus bone in this region of interest. And then we have formation and resorption measures that we quantify with histomorphometry. We can see the things that you often see just in schematics in textbooks, like a remodeling cycle with osteoclast in the front, osteoblast, osteoid, mineralized bone. But these things you can also see under the microscope and quantify with your histomorphometry setup. And finally, the measures that are dependent on the tetracycline label, these are called dynamic bone formation parameters, because they really reflect how much the osteoblasts were working in these 2 weeks between the 2 tetracycline labels. Unfortunately, there is no dynamic bone resorption marker. So for bone resorption, histomorphometry has less to offer than for the bone formation activity. So here, this is how we do these measurements. For the tetracycline labeling, you quantify the length of the deeper line, which is the first 2 days of tetracycline, and then the second line, and then the computer that you use for measuring these things determines the length of the label, the distance between the labels, and how much bone is between. And that corresponds to mineralizing surface, mineral apposition rate, and bone formation rate. So that's terms that you often hear in this area. So in the end, we put all these results into one table, and that's our standard histomorphometry report. So for all these structural, static formation, dynamic formation, bone resorption markers, and we compare it to controls that we established more than 20 years ago. Yeah, so that is the final report for clinical purposes. So in the end of this presentation, I just want to show some basic results for histomorphometry. One important thing, at least in pediatrics, is that the size of the sample is age dependent, as is intuitive. So in younger children, the bone sample is smaller than in adults. So overall, we find an increase by about 50% or so between 2 years and 20 years of age. Another change during growth is an increase in the amount of trabecular bone. So this BVTV parameter increases by 59% from 2 to 20 years of age. And you can see that here in the sample of the 20-year-old compared to the 2-year-old. You see that the trabecula are thicker in the 20-year-old, and that's the increase in trabecular thickness is the reason why there is more trabecular bone overall. All right, so then in terms of diagnosis, we have 2 groups of disorders that we can distinguish with histomorphometry that both on a clinical level will lead to low bone density, and one of them is osteoporosis. You can see here a case of osteoporosis. You can see that the trabecula are very thin and are like isolated islands compared to the control, where they are much thicker and better connected. So that's one of the hallmarks of osteoporosis, that typically you don't have much trabecular bone, so meaning in histomorphometry language that it's a low BVTV. So osteoporosis means there is not enough bone there, and that's usually because the bone has been resorbed or has not been formed. The second type of disorder that clinically could lead to low bone density is a lack of mineralization. That's called osteomalacia. In osteomalacia, you see a lot of unmineralized osteoid here. This is not an ideal magnification here to show this, but you can still see that there's a lot of red material on top of the green. So you have a high percentage of unmineralized osteoid in this sample. And in the right sample here, you have the osteomalacia and the presence of a normal amount of trabecular bone, just eyeballing it. And in the left sample, you have a lot of osteoid, but at the same time, you have a lot of bone. So you can have, increased bone mass despite a mineralization defect. That is really two independent things depending on the condition. So mineralization defect means that the osteoid is mineralizing very slowly and after some delay. That's shown in a better magnification here in a case of a child with hypophosphatemic rickets. So on top, you have a control sample of a 10-year-old girl. You see the mineralized bone in green, unmineralized in red. On the tetracycline label, you can see two lines that are clearly distinguishable. And in the lower part, the biopsy from the girl with X-linked hypophosphatemic rickets due to a FX mutation, you can see that the osteoid is much thicker. You can also see that there is some unmineralized bone around the osteocytes, which are these small cells inside of the mineralized bone. And that is a hallmark of X-linked hypophosphatemic rickets, and that has different names, but widely it's called periosteocytic hypomineralized lesions. And when you look at a biopsy from a patient with XLH under a fluorescent light, when there has been tetracycline labeling, you can see that it's blurred, so you cannot distinguish the two courses of tetracycline that were given. When we look at samples from patients with OI, so that's our pediatric osteoporosis disorder. We see almost always that the sample is smaller. So the core width is smaller in OI typically than in the controls. And you can see also that the amount of bone varies with the severity of OI. So in type 1, typically you have a cortex that is quite well structured. Whereas in more severe OI, like type 3 here, you have a very thin cortex, and that's often, as thin as a normal trabeculum. So here's a publication of these different OI types compared to reference ranges. So you can see that the core width tends to be small, or really much smaller than normal in all these OI types. And the cortical width is almost always decreased in type 3 and type 4. And trabecular bone volume also is below the reference range in type 3 and type 4 in most cases. So what is interesting in histomorphometry is in particular the activity of bone formation, bone resorption. Unfortunately, that's not so easy to capture in pictures, but the numbers are there to document this. So in OI, what we see is that there is a lot of osteoblasts. So here, all the results are shown as in percent of the age-specific reference range. So you see that in OI, in the different OI types, you have increase in the amount of osteoblasts. You also have a more mineralizing surface. So when you look at the bone, you see a lot of tetracycline labeling. The distance between the tetracycline label is decreased, but the bone formation rate is still on the high side in OI typically. And you also have an increase in the number of osteoclasts. So, so that's like the average result in osteogenesis imperfecta, where you have an increase in both bone formation and bone resorption, which indicates, that the trabecular bone mass is low because of increased bone resorption, because you have actually increased bone formation. That's what many people don't know, that in OI you really have increased bone formation. So the reason you have low bone mass is because the bone is resorbed very rapidly. And finally, you can use histomorphometry to look at the effects of treatments, of interventions. And this is shown here in the example of bisphosphonate treatment. When the bisphosphonate treatment was new, here in Montreal, biopsies were taken like systematically before and after about 2 years of treatment. So we had 45 patients with paired biopsies. You see here an example of a boy who started the treatment at 3 years of age, and over the next 2 years, the cortical thickness increased a lot. And that's what we see in most patients, that cortical thickness increases. Trabecular bone volume also increases, but a bit less than the cortex. At the same time, you see that the tetracycline labeling is more sparse, or in this particular field, not visible at all, because the bone formation and resorption activity decreases a lot. So you can see with all these parameters that we measure that they go down with bisphosphonate treatment. And finally, when you give bisphosphonates, you have these lines that appear under the growth plate in the long bones. You can also see these lines in the ilium. So in some patients, by accident, we took the biopsy a bit too close to the iliac crest, close to the growth plate there. And then you can see a biopsy of these lines. So here on the right side, you have an example of that. So the growth plate of the ilium is shown on the top. And then you have these individual lines that are visible here as horizontal trabecula. What you can do is you can also distinguish mineralized bone, which is darker than mineralized cartilage. So you can distinguish actually what is mineralized cartilage from the growth plate that's remaining in each of these layers of bone. And we quantify that, and we see that with increasing distance from the growth plate, you get less and less cartilage. So this indicates that the bone that's formed under bisphosphonate treatment and that makes these lines is remodeled. So over time, you get a lesser percentage of mineralized cartilage in the bone. So I think that's it. A summary here for this presentation is that you can use histomorphometry for diagnostic purposes, for evaluation of new treatments. That's why FDA is quite keen on getting biopsies, at least when new treatments are tested in adults. Biopsies can be used as measures of efficacy and safety data, and it's quite a versatile method. You can measure structure, formation, resorption, but also anything else that you find interesting or that's relevant to your question, like we saw in the last example, these individual treatment lines. So whatever is the question, you can quantify that with histomorphometry. And I think that's it. Yeah. So thank you for your attention.